or a CT scan to also make sure if there's an IFP or rule out IFP or where it is exactly, so that you know, how to remove it or how to approach it. And the most important is, of course, the patient has perception of light or not, because that becomes again a issue which you take up as a prognostic outcome factor before you touch the case. So the best time to intervene is about 2 weeks. By then the initial inflammation because of trauma has come down, and the eye is more viable to be, in a way, surgically traumatized again, but because before that it would bleed a lot more. So once we've decided to take the approach, I also stressed in the previous talk that the wide-angle systems are almost mandatory now for these kind of cases. We use it for all cases, but for these kind of cases, almost always mandatory. So I'll show you an assortment of a few cases where post-trauma as a secondary repair, how things work. This is again, as you see, a very bad, grossly mutilated eye in some form. A tear has been repaired in the past. There's already a lot of tissue in the anterior chamber. From outside, you can't make out how much is the corneal involvement or how much is the tissue which is at the back, which is responsible. So slowly you can see that once we start cleaning it up, you can see that there is an open patch in the cornea, which is clear. It's not totally kind of opaque. And that is where it will allow us to see things behind. So a lot of times from outside we feel that the eye is non-viable by looking at the cornea, but from inside, once you know an ultrasound finding and the patient has perception, it is worth it to go in and check what's happening. Like in this eye, the back of the eye was not as bad. It just had this hemorrhage which was there, and of course some residue of the trauma. The disc would be pale, but then there would be viable tissue behind, and it's not just because interiorly it looks bad that you leave it. So the end, you can make this optical opening in the iris in this area, even though the lower part is bad, and you can get away without a graft in this situation. Next is if the patient presents to you with endophthalmitis and also has an IOFP. Now here, the main thing is that you need to do vitrectomy as a primary procedure in these cases. So here the approach would be that you kind of repair the tear which is there, and once you've reassessed where the foreign body is, in this there's a cataract also, so we approach it with a lensectomy with, here it's endophthalmitis, so we are kind of taking off the lens as a whole. Otherwise we usually do leave behind capsules to replace at that stage with the intraocular lens during the same sitting, but because of endophthalmitis, our aim is to salvage the eye at this go. So once you've cleaned it up and you go back, you can see that there's this huge foreign body behind and it's causing tremendous inflammation. It's filled up with exudates and surrounding it, as well as causing a lot of inflammation around that whole tissue. So once again, the aim is to clear off the vitreous, free it up. You can see there's so much vascular affection. There's almost like a frosted branch meningitis kind of appearance which has come up, and is all because of endophthalmitis. So slowly we remove all that tissue which is there, and in these cases sometimes we remove the hyaloid. We just don't do a core vitrectomy and then put silicone oil at the end after removing everything, because these eyes are prone to breaks and detachments, and the oil kind of compartmentalizes that, as well as saves the eye from going into a bad detachment which can't be managed because of trauma. This is a small clip which shows actually a foreign body which has gone subretinal and is not seen from outside. We just know we've localized it, but is not seen from the tissue. And in this case, there's an endoscope by which you can actually see its position in that particular area. So in some situations, you could use adjunct tools like an endoscope to actually see where it is. This is a view from an endoscope that is enmeshed into the subretinal tissue. So you kind of put the magnet with the use of an endoscope view and then remove it, and after that, of course, you can shift back to your normal view to take it off in that sense. So it's almost like entering a cavity where the foreign body is, and removing it and then getting it out through the sclera in some form. As we saw with giant tears, there's also complex PVRs which come up once you do a secondary repair. Once a patient has trauma and then he forms a bad detachment and he comes to you, sometimes you see eyes like these where everything is filled up and you don't know where to start. So in such a situation, we clean up the vitreous and then slowly reassess. You can barely see a small opening now into the tissue which is admixed with vitreous fibrosis, and then slowly you start seeing some vessels, although there's a big tear in this area and is all fibrotic at this stage. So slowly I'll just take you fast forward through it, that we again use the same approach as I showed you for the giant tears. Slowly fill up the PFCL up to the edges, remove traction, still cut more. Here the tissue is pretty stiff in the periphery, so you actually need to do a lot of diathermy and cut it. So I'm just trying to show you that sometimes you need to almost leave a small patch of retina in the center which is viable, and in a guarded way keep doing the retinectomy in areas. There's subretinal tissue, so we have everted the flap and removed that. So eventually what is left is only a central tissue, and of course visual prognosis is not extremely good, but these eyes can still retain some backup vision in some form or the other. Macular holes is again another thing. Blunt trauma leads many times to macular holes, and this is a typical case of a blunt trauma causing Berlin's edema with, you can see a lot of pigmentary changes which are there, and a macular hole, and the surgery done is the same. You remove the hyaloid and then peel off the ILM from there. So it's pretty much straightforward. In the past, it used to be believed that traumatic macular holes are different than the iatrogenic, the ones which are idiopathic, but now it is well understood that they also behave the same way. Only thing is prognostic outcomes would depend on how bad the macular area is damaged because of the pigmentary alterations in that situation. This is just an example of pre and post macular hole closure. You can see that even on the OCT there is thinning of the retina, so obviously their prognosis would not be as good as what would be there with idiopathic macular hole, but no doubt they do improve to some extent, and one should give them a chance. Sometimes you are faced with these bad suprachoroidal hemorrhages, so these are approached at about 2 weeks time when there's liquefaction. And again, it's a combined procedure where you do a vitrectomy and use a lot of perfluorocarbons to tamponade the part which does not have the suprachoroidal hemorrhage, and then you need to drain it. Here there is a big suprachoroidal hemorrhage superiorly, so we are kind of forming an area in this particular superior area to find a drainage place of the sclerotomy after localizing. And here you start off with an AC maintainer because there's such a big choroidal that your pars plana cannula won't stay in. So once an AC cannula maintains the pressure, you get a view inside. There's a huge choroidal here. There is some retinal detachment in the inferior part as well, which we can see. But we get a mild view of the fundus, although very dull because of the exudate or the inflammation which has collected in that part. So you can see that we slowly clear it up with the AC maintainer in place, and slowly the view of the inferior retina improves to some extent. After that, we drain this part from making sclerotomies, and you can see the dark blotchy blood which is coming in from there. And you need to keep reassessing, maintaining the pressure inside and then making the sclerotomies and seeing whether the choroidal is going down inside, and slowly you will, it kind of regresses to some extent. So you can see now that it has gone back to some extent, and then of course we should top it up with oil as a tamponade because there was an inferior detachment in these cases, and then seal off all the sclerotomies which were there. Thank you very much. I think we're falling short of time.
Thank you, Manish. Manish, there is a lot of talk about Densiron and heavy silicone oils. So in your trauma cases with retinal detachment, do you prefer going for heavy silicone oil, or there are certain indications where you use it?
Well, personally, I don't have much experience with heavy silicone because I've seen a lot of people facing problems with removals and a lot of complications. So I don't have a major experience. I've tried it in a few cases, but I somehow feel that the regular 1000 or 5000 centistokes is working fine. So I'm not the right person to actually tell you more about it.